Okay. So I'm going to record this class so that Cheyenne and Glennis can view it. Get at least some of the attendance for the week and get caught up on the script. But cardiovascular we'll cover on Wednesday. Respiratory and dermatology I would like to cover today. Not that they're all that much more simple, but cardiology just is a huge area of therapy with lots of different kinds of drugs for different purposes. I'd rather have everyone here for that class. So, to begin with, do you have any questions from last week? No. Pardon? No. You don't have any questions? Okay, that's fine. Do you have your antibiotic chart? Okay, good. Have you had a chance to look at the Framingham study? No. Okay. Oh, good, good. That's where you need to be. We'll talk a lot more about the cardiovascular issues because this is mainly the Framingham study is mainly to do with cardiovascular risk. And it was deliberately set up to be a relatively straightforward set of data because the number of people they wanted to participate was large, and quite frankly, the more complex you make it, the less likely people. That makes sense. So we'll put all of that off. So I'm glad you've been thinking about that. And remember, you're supposed to also do it for yourself. So maybe on Wednesday we can have you guys practice blood pressure because I know you need to review it. It's something that it's sort of like it's not exactly like riding a bike. You do have to practice it now to really be able to get an accurate reading. So we'll have you guys do that for each other. One thing I wanted to mention, have you done your FAFSA for this year? You have? You've talked to Kelly then? Okay, good. Well, for Glennis and Cheyenne, if you haven't, you need to talk to Kelly as soon as possible. FAFSA is a requirement for you to have your Title IV funding, your loans, and Kelly's a big help with that. So, but remember, you also need taxes done, so that requires a tax form. The sooner the better. We'd like to not have this go down to the wire, and in May we're all running around trying to get everybody to do this. So I'm glad you've already done that, Sorry. Thank you. So now we're going to talk about respiratory issues. I've got a handout, and we have and what I'm going to do now is take a minute to pull something up. if you'll bear with me. Patience. My computer is not cooperating with me this morning. Okay, now let's get back here. Okay, that's what I wanted to have. Okay. All right. Okay. So the respiratory system is controlled by the autonomic nervous system. The autonomic nervous system controls is really controlled by the neurotransmitter responsible is acetylcholine, and basically it controls the things that we don't think about. They're in other words, the autonomic means that it just automatically happens, as opposed to having it by volition, and so the autonomic nervous system controls our respiratory system, our heart, our peristalsis, many of the things that happen just to keep the body running. So it also involves smooth muscles, which includes the bronchus and the pulmonary system. So that's where we have this going on. So we have both the parasympathetic and the sympathetic. You've had all this in A&P systems. But in both cases, the autonomic system, the parasympathetic side, controls vasoconstriction and bronchoconstriction, in other words, when the muscles contract. And the sympathetic side of the autonomic system is responsible for the relaxation or dilation of these muscles. It's a very complex system. We'll talk more about the nervous system at another time, but it's a very complex system, and that, as you can imagine, it has to function under all sorts of different stresses in order to keep us alive. So we have a lot of different sides to that. This is not an A&P class, so basically you can go back and review that if you want. But the The system is basically divided into the controller, which is the central nervous system, which controls then also the peripheral nervous system, which is everything outside the brain, and that controls the motor system, which basically affects muscles and glands and stuff. And then we have the autonomic system, which has both the sympathetic and the parasympathetic side, and then the somatic nervous system. Somatic merely means that we control it, okay, and we can teach it. Somatic system, autonomic system, basically runs on automatic, so that we do have that. So many of our basic systems are controlled through the autonomic system. There's a lot of different drugs that we have. There's a lot of different roles that are controlled by the autonomic system. The role in respiration is really to alternate between bronchodilation and bronchoconstriction, and this is what allows us to breathe. As I say, we do this on our own. We do it whether we're awake or asleep. As long as we're alive and our muscles work, we can breathe. And of course, the respiratory system is responsible for gas exchange, for getting oxygen into hemoglobin and the red blood cells, and for getting carbon dioxide and other gases out of the blood. And it does this through methods or through mechanisms that you've that you've already become familiar with. It starts with the nasal system, and the larynx and pharynx, everything basically from the nose to the lungs. We go down through the trachea. You remember the trachea, there is one tube that leaves our throat and goes down and then divides into two. One goes to the lungs, the other goes to is the esophagus going to the stomach. And there's a valve that is there, the epiglottis. When we are swallowing, the epiglottis closes off our airway. And when we are breathing, the epiglottis opens so that we can breathe. The function of the epiglottis is to keep things that we don't want in our lungs out. Right now, we're going through a time when I think that at our house with my mother-in-law, where her epiglottis isn't working right. And so she has a very difficult time swallowing things without them going without them going the wrong way. And it's very disturbing, but what to do about it, I don't know. The other functions of the respiratory system include controlling pH, the amount of acidity in the blood. The pH is slightly basic, very slightly basic, for various reasons, and it's buffered by a complex series of chemicals, and CO2 is a part of that. But the regulation is such that we can get rid of the acidity by breathing harder, and the acidity comes from CO2 being in the blood. So we start circulating faster and breathing faster to reduce the CO2, among other things. It's also good for heat exchange. Obviously, the respiratory system is responsible for us being able to speak. We have our vocal cords. The voice goes through there, and we learn as infants how to control those vocal cords so that the sounds we make can be understood by others. Smell is an important part of the respiratory system. Smell and taste actually are very closely related, but smell uses receptors in the nasal cavity to tell us, as both a warning and an attractant. So the warning is, very, very dangerous smells. We learn to recognize those. We breathe in, goes through the trachea to the bronchus, and then the bronchial tubes into each lung, and the lungs then divide all those tubes into smaller and smaller units. The bronchioles going to the alveoli, and the alveoli are where we do our exchange, right? Remember that from A&P. Alveolar function is one of the things that is compromised in diseases like emphysema, and we have a hard time then exchanging the gases. There are some we can change the pressure within our lung by simply closing off the epiglottis and pushing hard, exhaling hard. That increases the pressure in the lungs. It can be used to change several things. One of them is a heart arrhythmia called paroxysmal supraventricular fibrillation, or we use it also to clear our ears. The act of swallowing also can help us with that, and of course there are other times when we actually put pressure on our lungs. So there are lots and lots of different kinds of respiratory, modified respiratory movements. Regular breathing is that. It should be very regular. We can control it to a certain extent, but if you try to hold your breath to suffocate yourself, you eventually pass out, and then you just start breathing. So it's very hard to hurt yourself, but we can change the rate at which we breathe. And we can even stop breathing for a short period of time voluntarily. But the body wants to breathe. So there are other things that happen. The laughing and crying will produce, by varying chemical mechanisms, endorphins, which are mood changers, and they can be very important modifiers of behavior. Runners often will, we call endorphins sometimes natural opiates because they can make us happy. They can also make us unhappy. Coughing and sneezing are important ways of clearing material from our airways. Coughing also involves moving things up out of our lungs. Sneezing generally clears the upper airways, whereas coughing clears the lower airways. They both will do both at the same time, but coughing is often a way of getting mucoid material out of the lung, which the lung produces in response to irritants going into the lung. And an irritant is almost anything that doesn't belong there. We think of yawning as something that happens when we're tired. and to some extent it is. But yawning also happens when we have too much CO2 in our lungs. So theoretically, if you are healthy and you breathe appropriately, and if you will breathe deeply, you shouldn't be yawning as much. However, that's hard to know. Another function of the respiration is the regulation of blood volume and pressure. The lungs help us with the release of angiotensin converting enzyme, or ACE. And right now, that is part of the blood pressure mechanism, changes angiotensin 1 to angiotensin 2, which is a blood pressure regulator. This is why the ACE, this is where the ACE inhibitors actually work in the respiratory system to decrease blood pressure. So there's a diagram here on one of the slides of the human breathing system. We just talked about that. We have the trachea, the bronchus, the bronchioles, and the alveoli. Remember also that we have all of this is controlled by muscular action. And the muscular action is to expand the rib cage and thereby expand the lungs and suck air in, and then to close the rib cage a little bit and then push air out. We can also, the diaphragm is a function here. If we really inhale deeply, then we're going to be lowering the diaphragm more. Between the diaphragm and the intercostal muscles, we expand the lung volume and contract the lung volume. And we can push air out of our lungs by contracting those intercostal muscles and pulling the rib cage in a little bit and pushing the diaphragm up to shove air out of the lungs. If we just breathe lightly, we don't breathe with our entire lungs. One of the reasons that we another reason that we yawn is because we don't breathe deeply enough. And so we get CO2 pooling in our lower lobes of our lungs. And so it's probably a good idea periodically during the day, fairly regularly, to take a series of deep breaths and hard exhales to clear the lungs of that carbon dioxide laden air. It helps keep the lungs functioning much better. So how does the gas exchange work? We have, remember, blood goes from the heart to the lungs. The only arteries that carry deoxygenated blood are the pulmonary arteries. The only veins that carry oxygenated blood are the pulmonary veins, those that return oxygenated blood to the heart for pumping into the body. So the blood goes into from the pulmonary artery. The pulmonary artery breaks up into a series of arterioles, and then those arterioles break into a series of capillaries on the surface of the alveoli. And the capillaries are permeable to gases like oxygen and CO2 and other gases, unfortunately, gases like carbon monoxide and the sulfur oxides that are toxic. So what happens is the blood is exposed to oxygen at the alveolar membrane, and oxygen displaces carbon dioxide on the hemoglobin, and then the carbon dioxide is kicked out into the airway to then to then be expelled. Excuse me. Getting another one of those phone calls we discussed the other day. And it works because oxygen can displace the carbon dioxide. The reason carbon monoxide is so toxic is that oxygen is that it binds stronger to hemoglobin, to the iron in hemoglobin, than oxygen. So oxygen can't displace it. So we have to wait until that red blood cell is recycled to get rid of it. So that's why carbon monoxide is so dangerous. It cuts off our ability to exchange oxygen. So the mechanics of breathing, okay. We inflate and deflate the lungs. Inspiration is the creation of negative pressure inside the lungs relative to the atmospheric pressure outside. And so when that is lower pressure than the ambient pressure, we inhale, and then we exhale. Expiration happens when we increase the pressure in the lungs and push the air out. Okay. And we do that, we push the air out, obviously, to get rid of the carbon dioxide. So it goes in there. The gas exchange is two different things. There's an internal and an external. The internal is the gas exchange at the capillary level, where O2 is put into the cells and CO2 is taken out. Or rather, O2 is lost to the cell for purposes of generating energy. And CO2 is put on, and then it goes back into the lungs, circulated through the lungs, and at the alveolar level, the CO2 is gotten rid of, and the O2 is added. So it's a constant process. So we have lots of things. The lungs have a volume. We only use a small amount. The lungs have quite a bit of volume. Almost well, it's about 6 liters of volume. So about 6 quarts of volume. We only use, if we're at rest, we only exchange about 500 milliliters, or 1/12 of our total lung volume at any one time. We can, with a bit of force, we can actually add another about a little over 3 liters to that. So we have the ability to inhale quite a bit. Exhaling is not as easy because, of course, we're trying to compress the lungs, and we can actually force about 1.25 liters out at any one time. The residual volume is used for coughing or forcing, like a Heimlich maneuver. You remember that for someone who's choking? We use that. So we have a fair amount of air that can be moved around if we work at it. We can't ever totally empty our lungs. In fact, we don't want to. And so we have a total lung capacity, as I say, of about 6 liters. When we do, you did in vital signs in Med 102, did you use the respirometer? Yeah. Yeah. this is a way, one of the reasons we use a respirometer. The lungs are, part of lung function is to clear stuff out. And one of the reasons that we use the respirometer is, especially for bedridden patients, they tend to not breathe very much. If you are just at rest and all you ever exchange is about a half a liter of air, what happens is you not only build up that carbon dioxide in the lungs, but you also start building up fluids. Because one of the other things is when we exhale, there's a lot of fluid, there's a lot of water that comes out. And so patients who are hospitalized are generally asked to use a respirometer or a spirometer a couple of times a day to try and keep their lungs clear. We're trying to help them not develop pneumonia. And pneumonia starts often by a buildup of fluid in the lungs, which in that nice warm environment is a great place to grow viruses, bacteria, fungus, etc. All those nice microorganisms that we talked about last week. And it really is a kind of a hard, a difficult thing to deal with. Many of us, if we're immune competent, will get up, if we're in the hospital for a few days, like, for any of us, there may be a time when we are in the hospital for a few days. Generally speaking, if we're otherwise healthy, we'll get up and walk out and be fine. But people who have who are bedridden often have that problem. It's one of the reasons we use a spirometer, is to try and keep people using the volume of their lungs. You remember when you pushed, you could actually see the rate, and you were always looking to get a volume that was in a certain range on the spirometer. That was so that we can be clearing out of that lung. So there are all sorts of noises that our lungs make. And it's a lot of it has to do with liquid water in the lung, and has to do these different sounds that we can hear from when a doctor sticks a stethoscope up and asks you to breathe, can give us some ideas as to problems that the patient may have. Usually there are things in there, all of us have some sounds. There's a little bit of wheezing. There's occasionally some other sounds, but the issue is we're listening to see if there is more noise than there should be. And what that means basically is something that doctors and nurses, etc., are trained to listen for, that indicate that we're starting to build up fluids. And that's why that's why we have some noises that elicit a response from the respiratory therapist, who then come in and suction out a lung. Have you ever seen someone get their lungs suctioned? It's a pretty ugly looking process. What a respiratory therapist will do is feed a tube into your lung, down into the bronchus, but not much further, because it doesn't want to break any important vessels. But then they'll literally suck liquid out of the lung. And this is done with patients who have pneumonia. It's done with other patients as well, sometimes with patients with cystic fibrosis. Another thing you might see a respiratory therapist or even a physical therapist doing is percussion. And that is they will actually beat on the chest or back of a patient to stimulate the lungs to cough out mucus. One of the characteristics of cystic fibrosis is a buildup of really thick mucus that provides a wonderful atmosphere and environment for the growth of microorganisms. And so many times cystic fibrosis patients will die of lung infections from the buildup of this material. So one of the therapies for cystic fibrosis is percussion. And it helps keep the lungs clear, but it needs to be done depending on how involved the patient is. It needs to be done sometimes several times a day. But these things can be used. Okay, a respiratory disease is defined as any disease, excuse me. Well, I'm having a rough time. Yeah, there's been a lot of illness. Respiratory disease is any disease process that interferes with gas exchange in the lungs, and thereby changes the concentrations of oxygen and carbon dioxide. The various pathologies we see are bronchoconstriction, which is a narrowing of the airway. Bronchoconstriction makes it hard to breathe. We have something, a class of diseases that we call reactive airway disease, which include asthma and various stages of the respiratory stages of hypersensitivity reactions. And we also have respiratory syncytial virus, RSV, that is very serious in infants. Most of us, as older people, have now become, like I would guess that I'm probably immune to RSV. I've probably been exposed many times. We didn't have treatments for RSV when I was a kid, so obviously I survived it, and is one of the viruses that causes the symptoms we call the common cold. There are diseases that are chronic. Things like asthma, things like chronic obstructive pulmonary disease, which is really sort of a catch-all term for people whose lung function is compromised. Emphysema, which is basically a sclerotic condition in which the alveoli and their function for gas exchange are compromised. And so we can't exchange oxygen very well. That's why emphysema patients are given oxygen in varying degrees in order to increase the concentration and force the exchange, even with the compromised and alveolar function. And then bronchitis, which is an inflammation of the bronchi. All of these will impede our ability to breathe. Asthma is one of the most common diseases we see these days. When I was a kid, asthma it seemed relatively rare. That could be because I'm just ignorant. I don't know. It seemed that asthma wasn't as big a problem as it appears to be today. Now I can't tell you how many people I meet that are carrying inhalers. So asthma is a mix of bronchoconstriction, chest tightness, They can't breathe very well, shortness of breath. All of these things um, um, are part of the asthma spectrum. And triggers can be a lot of things. Um, People have it from allergens, they have it from air pollution, uh, infections. I mean, asthma patients really should be concerned about lung ailments because they're already of compromised lungs. Um, in some cases, cold air, and then exercise-induced asthma is very common as well. Um, Basically, there are people that already have some sort of impairment in their ability to exchange air, and exercise means that they have to breathe. They're breathing harder. They're trying to exchange much more air, and it's very much difficult it's more difficult for them to do so. So I know some people that go out and exercise, and you can see them. They'll be exercising, and then they'll go pull out their inhaler. And I just look at it and I think, why do you push it that hard? And why do because exercise can take many, many different forms. And in fact, just spending 20 minutes walking around the block is probably sufficient for a lot of people without going down to the gym and working yourself hard. But the asthma pathology is in the acute phase can be caused by the trachea and the bronchi narrowing. Okay, that's why we have and it can be caused by a number of different physiological issues, but also this another phase of asthma activity is an inflammation of the airways. Inflammation causes constriction as well. And that's why asthma patients will often have two different inhalers. One we call their regular, their steroid inhaler, which they'll take once or twice a day. And then they have a rescue inhaler, which is a bronchodilator, where for acute phases when they can't breathe. So we have the lots of different things that happen. The inflammation part leads to the production of a response to try and deal with the inflammation, which could be edema or mucosal thickening. So there's a slide here about the anatomy of asthma. If we look at the picture on the left, we have a picture of a theoretically a healthy lung, healthy set of alveoli and bronchus and being fed by the pulmonary artery. We look on the one on the right, what we see is a thickening of the bronchial muscles because the hypertrophy of that muscle comes from the amount of work you have to do in order to be able to breathe. So you notice that there is that the airways are narrower, the alveoli are bigger, and they get filled, they get air trapped in there. And it's hard to breathe. It's hard to get enough enough gas exchange because the alveoli are blocked often. So it's an interesting condition, and one that if you don't have it, you're happy not to. So we have The pathology, basic pathologies, as I said, are bronchoconstriction and inflammation. And all treatments are aimed at relieving those symptoms. The problem is we're not sure what causes asthma. We know about triggers, but we don't know why some people standing in the same environment, breathing the same air, some people will have asthma and they'll have an asthmatic attack. And the person standing right next to them has no response whatsoever. So we don't really understand asthma very well at all. So we have the broncho. There are a number of different kinds of drugs, and we'll talk about those after we take our first break. Okay, so why don't you take a break, and we'll talk about that after the resume the recording. So there are lots of different medications that are used to treat asthma. They fall into a number of different categories. We have one other thing that I wanted to go back to actually in terms of chronic obstructive diseases is actually lung cancer. Lung cancer obviously involves, cancerous growths in the lung and compromised lung function. The lung cancer has a number of causes. It is most directly associated with smoking, of course. But there are non-smoking related lung cancers as well. Often those are very aggressive and nasty diseases, and basically they basically interfere with your ability to breathe and exchange gases. So with our treatments that we have for asthma, the major treatments involve relief of the bronchoconstrictive phase of the disease or of the inflammation, both of which are major problems. The bronchodilators include things like albuterol. It's a classic drug. The drug itself is used for acute symptoms. It is usually administered through some sort of metered dose inhaler or via nebulizer. If you've been in a hospital and you've seen people on a nebulizer, sometimes that's what's being given. There are some drugs that are used for chronic use. People who have a long-standing disease generally will have something that's given over a long period of time. Salmeterol is a good example of that. Sometimes they're delivered by what we call a discus, which is basically it's an inhaler type thing where you place a container, a little disc that contains the drug. You pierce it, you inhale it. The metered dose inhalers are used a lot of times because they will keep a track of how much drug is there, so that you know when to change the drug container. The inhaler itself is a unit that you put a container of drug into and inhale. You may have seen some of this in some of the other classes you've had. You may have seen some of these devices. For acute use, there are some others, and there are quite a few drugs that can be used. The many of these are selective in terms of what they'll act on, and some of them are non-selective. For emergency use, we use things like epinephrine. The EpiPen is used for someone who's gone into a severe case of bronchospasm, sometimes from a hypersensitivity reaction. And that's why we have people that carry them, because one of the hypersensitivity responses is to shut down the ability of the airways to function properly. Anyone who has a hypersensitivity reaction to, if you've seen this with peanuts or nuts, it's very, very rapid, and it's really scary. And it's one of the reasons that we are concerned, since, again, we seem to have more and more of these kinds of allergies appearing in our society. When I was a kid, nobody was allergic to peanuts, or very, very few people. And now you can't have anything in a school that has peanuts in it. You can't have other kinds of things like that. But peanuts are something that the allergy has gotten so common that they won't allow you to even send a peanut butter to school anymore, which is, that used to be a staple when I was a kid. Yeah. And the issue is that we're concerned about the safety of our children, and that's legitimate, but it also makes things kind of hard. But we use these drugs for bronchodilation. There are several of them. We use these non-specific ones because, again, it's a complex disease, and the different kinds of receptors, beta 1, beta 2, alpha, etc., that are involved, you don't necessarily know. So we use these beta blockers for various purposes. The beta 1 are primarily cardiovascular, and the beta 2 are basically airway constriction, responsible for that. So the bronchodilation, there's quite a bit of information about how these things work. We won't go into a lot of those details here. You can read through the entire handout and the entire and the text about what lung function we're dealing with. The other side of that is there are lots of different uses. We have as I say, the beta 2 agonists actually have an effect on mast cells, which release a lot of these chemicals and cause a lot of the problems. But we use it to treat some of the side symptoms of both asthma and other diseases. Another series of drugs that we use are to treat the inflammation side. And corticosteroids are the most common. Corticosteroids mimic the action of cortisol, which is a natural steroid that the body uses to reduce inflammation. So we have several of those that often patients that have asthma will take on a regular basis. And they often will take them on a daily basis. Chronic asthmatics will be taking, as I say, an anti-inflammatory regularly, and then when they have trouble breathing, they'll use the bronchodilator. There are lots of different places that drugs act in treatment of asthma. Management itself uses a mix of the adrenergic drugs, the beta-2 agonists like albuterol, steroids. Theophylline is often used as another bronchodilator. It's an older one. We often will encourage asthma patients to drink, to hydrate well. And occasionally, if someone's having a major attack, we'll put them on IV fluids and increase their oxygen intake, and also to help help reduce the mucus buildup with several different kinds of drugs. There's a lot of research on asthma with being done now as we understand just how serious this disease is. Chronic inflammation is one of the things that has been associated with multiple diseases, not just asthma, but chronic inflammation has been associated with cellular changes that lead to cancers. And so what we are discovering is that we have lots and lots of sources in our environment that give us this chronic inflammatory disease, and it's not just lungs. Want to move on to looking at routes of administration. We have metered dose inhalers. We have dry powder inhalers. We have the discus form. We have nebulizers, which require you to be tethered to the machine, and of course we have the thanks to the F10. Metered dose inhalers have lots and lots of designs, and they work all basically the same way. They give a very specific amount. We have to teach the patients how to use them, but you activate it, and a very specific amount of drug is put into a chamber that you inhale. The specific design, whether it's a dry powder inhaler, you have to really teach people how to use these, because dry powders are hard to get into the lungs. And in fact, they tend to precipitate in the lungs. So we have to teach people how to properly suspend this finely divided powder into a chamber and then inhale it very quickly so that it actually gets into their lungs. The liquids are a lot easier. The lungs can actually handle liquids a bit easier if they are aerosolized, meaning, again, extremely small drops. But we have to teach people how to do this. The lungs are a great place to absorb drugs because of the permeability of the alveolar sacs. It goes right into the plasma, right into the blood. So it's a good place to absorb it. The lungs, are good places to grow bad drugs, and they're also good places to grow drugs. So we have lots of drugs that we can put in. The discus is basically a different really is a disc that you inhale the drug. You put the drug in a little blister pack inside the discus. It when you close the cover, it it will then rupture that pack, and then you can inhale the drug. And the there's a way that it works that is really kind of clever in that you have to activate it and again, you have to teach people how to use it. It's not intuitive. Nebulizers, basically, you'll see them in hospitals, you'll see them in homes. We need doses that can't be. The thing about especially the steroids, the corticosteroids, need any time that you use them, you need to teach the patients to do the rinse and spit, meaning they have to swish water around in the mouth and get rid of the drug that hasn't gone into the lung, because that can lead to thrush, which is a type of fungal infection, of an oral fungal infection. And people, you don't see this real often, but when I taught microbiology down in Denver, I had a student one time that what we used to do is we'd swab each other's throats in that class. And had a student one time that grew the most amazing fungus. And we could never figure out, he wasn't an asthmatic, so he wasn't taking steroids. And he hadn't been taking antibiotics recently. We never did figure out why he had a problem with this. Let's move from asthma to COPD, chronic obstructive pulmonary disease. Again, this is basically a disease that can have multi causes. Not exactly a catch-all category, but it's a category of diseases that can result from chronic bronchitis. Bronchitis is an inflammation of the bronchi that leads to discomfort, coughing, and lots of lung infections, or emphysema, which is usually associated with smoking, because the smoke leads to changes in the alveolar sacs that make it harder for them to contain gases. This is an irreversible change, and it has associated with it constant coughing, difficulty breathing, regular infections because we're not exchanging things, increased production, and of course, there's the cough that's associated with smoking. It does not really respond to bronchodilators because it's not a bronchoconstrictive disease. It is progressive, and it is really mainly it's mainly associated with smoking, although age can have a lot to do with it. My mother-in-law, who is 98 98, has never smoked in her life, and she has compromised lung function. And she's 98. And our lungs, like everything else, deteriorate as we get older. But we don't, there is no response to bronchodilators, and that's how we, um, differentiate it from asthma. What it is our small airways, the bronchioles become compromised. They become filled up with hard material that makes it harder to get air go through. Emphysema isn't just caused by tobacco smoke. Environmental causes like air pollution or exposure, continual exposure, say in the workplace, to respiratory irritants. You're working, say, in a machine shop where metal was being cut, or as a welder where you're going to be vaporizing metal. You're going to be putting metals into the air, and theoretically you can breathe those, and that can lead to long-term irritation and chronic obstructive pulmonary disease. All right. When we go back to looking at dosing of these drugs, we have, I talked about a metered dose inhaler. Usually you take puffs, you do a deep inhale or a deep exhale, and then inhale and then puff like that. Hold your breath and then exhale slowly. With dry powder inhalers, usually it's a one smooth continuous inhalation after you suspend the powder in the chamber. Lots and lots of, as I said, lots and lots of research in asthma going on. There are new products that come out periodically. We don't have too many absolutely new drugs, although what we do is we have different formulations and different mixtures of drugs. Some people will take a mix of corticosteroid and a bronchodilator. The corticosteroid is for the inflammation, and the bronchodilator obviously allows the airways to relax. And that's really how they work. It's not that they force them to open, it's that they allow them to relax, because the constriction is a muscular action. And so we want those muscles, it's like a cramp, really. So we want those muscles to let go. But not too much, because we still want to be able to control with them. Let's see. Side effects. All drugs have side effects. Okay? The anticholinergics often are associated with dry mouth, so that's something that is another good reason after you do any sort of inhaled drug to rinse your mouth out, because the dry mouth comes from the drug staying there. Sometimes you're going to get visual changes, different kinds of glaucoma. There are some other side effects that can develop in some patients. Obviously, this would be limited to men, which would be prostatic hyperplasia. It just means an enlarged prostate. That's a benign disease. The only thing it really does is it obstructs in the men, it will obstruct the ability of the bladder to drain. obstruct the urethra. So corticosteroids are these are drugs that come and go with popularity and with warnings. Corticosteroids are potent drugs, and they mimic a lot of natural products in our bodies, but they do work pretty well. Let's see. Adverse events of these: fluid buildup. You're much more susceptible to infection when you're taking corticosteroids. And some people actually experience muscle wasting and changes in metabolic function. Some of the later drugs, things like Montelukast, Singulair, are what we call leukotriene antagonists. Leukotrienes are potent hormone-like molecules that mediate a number of functions, many of them muscular. And they are active throughout the body. And they are something that these compounds weren't discovered until the 1960s. And the more we understood about them, the more we understood that they're part of the many pathways that lead to steroid synthesis in the body, among other things. But they are useful as the leukotriene antagonists, such as Singulair, will affect the chemical mediation. Leukotrienes actually cause bronchoconstriction. It can lead to edema, and so when that process is part of the pathology of your disease, they'll give you some of these things. The couple of different approaches: we can inhibit the receptors, that's what Montelukast Singulair does, or we can actually interfere with the biosynthesis of leukotrienes, which is something that has its risks as well, because they do have an important part to play in the body. We have a series of compounds called methylxanthines, and the most common of those is caffeine. And then another one is theobromine, which is found in cocoa. It's found, these things are also in teas, but we use these for the treatment of many of our symptoms of bronchitis and COPD, and to some extent asthma. Some of them are oral, which is a lot better than the inhaler. But oral drugs, remember, come on slowly because of the first pass effect. So they have their toxicities. We don't use them as primary treatments, but when patients are not responding well to the others, we will use them. Theophylline is used quite common. I mean, people take caffeine all the time and theobromine by drinking coffee and eating chocolate. Theophylline leads to bronchodilation by a direct action on the respiratory tract, a different route. Pardon? Theophylline, Theophylline. Phyllline. Yep, chocolate is good for you. Okay, There are other drugs that we can use for prophylaxis as opposed to acute treatment. These are drugs like cromolyn or nasal chrome. What they do is they interfere with the release of histamine from mast cells. And histamine is obviously something that is involved in reactions that are related to allergic reactions. There's lots of other information we won't go into in here about the individual drugs. What you should do is take a look in your chapter on. Pardon? You did. Okay. So yeah, are you talking about theophylline or theobromine? Yeah. Theobromine is one of the reasons that people push chocolate as a good food, but dark chocolate, not milk chocolate, because the amounts of theobromine in milk chocolate, because the amounts of chocolate in milk chocolate are much smaller. So those people that are like my wife who love dark chocolate find that a very nice excuse to eat dark chocolate. So, okay. So we're going to, I'd like to move on to dermatology from here. And what I'm going to do is, this is what I'm after. Let's see. There. That won't do. Okay. We'll talk about dermatology now. Okay. Obviously, dermatology is complicated. The skin, the largest organ in the body, has multiple functions. One of the major functions, besides keeping all of our other parts from leaking out, is prevention of infection. It's part of our first line of defense. Remember, I talked about the immune system last week, and our first line of defense really is our skin. It's a barrier. It keeps us from getting a lot of infectious disease. Obviously, that's if it's intact, but it too has its own diseases that can affect the skin. I'm going to give you a few of the functions of skin. Also helps us with the regulation of our temperature. It helps us with electrolyte balance and water retention. And this is where we absorb vitamin D. We talk about going out into the sun and using sunlight to activate our, to actually help us make vitamin D. So that's one method of that. You can also absorb it. That's where the vitamin D is formed and absorbed into the body. There are lots and lots of skin conditions and lots of descriptions of different skin. We call them lesions, and lesion is just some irregular formation. Skin itself is pretty smooth. And remember that the layers are the epidermis, the dermis, and the subcutaneous space. But we have lots and lots of different conditions that we can use for examination. If you go to a dermatologist, they're going to look at your skin. They're going to examine your skin to see if there's something that is not supposed to be there. Several of the things that can happen are elevated forms of skin irregularities. A cyst is an elevated circular mound that as it can be filled with either fluid or a semi-solid material. A macule is sort of a pigmented brown or colored spot. It just is on the surface. One of the most common is a freckle, and most people know about those. There are papules, which are basically elevated bumps. Acne is one of the most common. And pustule is something that has a content that has pus in it. The whitehead in an acne macule or an acne papule is actually the pus. The white is the pus, and pus is merely an accumulation of cellular material, usually to fight an infection of some sort. Is it bad to pop pimples? The overall answer to that is it can. What you need to do is avoid scarring. And there are people go back and forth on that. I mean, most people will do that. Generally speaking, what you want to do is get the infection out. There's several ways of doing that. One is to pierce it, and the issue is that you really shouldn't pop a pimple. What you should do is sterilize a needle, lance it, and then push the fluid out. Popping it is what leads to scars.
So the white that I thought was leukocyte.
It's the leukocyte debris that's there that is in response to a local infection. That's all pus is a response a bodily response to a local invasion of some sort. Pus can form around splinters, which is why splinters that you can't pull out, that get under the skin, ultimately, pardon? Yeah, ultimately, often they'll develop into a local infection, and you can lance and squeeze them out. And even those that don't come out easily, after a day or two, they're surrounded by a layer of pus, and they can often just be pushed out. If they're sort of barbed and you can't pull them out, you don't want to really rip the skin up. So, but anyway, so the same thing holds with a pimple. There's something there, usually an infectious organism. And the body's response is to first off send in the cellular defense, the leukocytes that go in and generate ways of killing the organism, and then surrounding the debris that doesn't belong there. That's what pus really is. There are lots of different schools on whether you should pop a pimple. As I say, the best thing you can do is not pop it, but let it get to the point where you can easily lance it with a clean needle, and then just squeeze the material out gently. Well, there are still often infectious organisms that haven't been completely killed off. Is it active? Well, I don't know what active means. I mean, well, it can, but also you want to be careful about that, because they can actually end up being ingrown, meaning it can go further in, it can grow into the body instead of out. And those actually, when it's an infection like that, we used to call those carbuncles. They were just deep, large cysts that would form pussy material. What happens ultimately with all of those is the body will clear it out. So when someone says to you, don't pop your pimple, the body generally, unless you have really something like cystic acne, which is the really disfiguring acne that people can have, generally speaking, if you just leave it alone, it'll go away. The body will clear it out. Most people don't like to do that because, of course, where do you have pimples? Well, mostly on your face. If they're on any other part of your body, nobody should be able to see it anyway, so it shouldn't matter. But so the issue is you want to get rid of that. Covering it up with one of the acne drying out products is something that a lot of people don't like to do because it takes a while. But it doesn't, clearing out the lesion isn't necessarily bad. But you want to be careful because there are infectious organisms there, and you want to be careful how you do it. So if someone, you have, like if your child is trying to do that, you should encourage them to express whatever it is, at least into like a tissue or something, to keep it from going elsewhere. But yeah, we were always told to leave them alone, and of course we didn't. Yeah, yeah. Yeah, that's, yeah, right. I'm not sure I want anybody doing that to me. I'm going to be gentler with me than they will. Although, it depends on where it is. My wife used to get little pimples on her back. She couldn't reach it. And they were very uncomfortable because they would rub against her clothes. And so she'd come to me and say, can this be dealt with? You know, can it pop? And I'd look at it and I'd say, well, no, or yeah, we can do that. But it is a little harder. Let's take our second break. It is a little after 10:30, and we're supposed to take breaks. Sure.
Like you were saying, in what, and they can't come out. Like sometimes splinters, you try to get them out, and you just make it worse when they get stuck in them.
Yeah.
What is it that eats them?
Well, the body responds to splinters the same way it responds to infectious organisms. It'll mount an immune response to isolate it and protect the body from it because it doesn't belong there. The body does not like things that don't belong there. So what happens with a splinter is that it'll be surrounded by leukocytes again, and it'll have a layer of material as they're trying to actually tear it apart and eat it. And so you build up this slippery layer that later on the thing just will slide right out. Oh yeah, yeah, because they get surrounded by this layer of slick stuff, the leukocytes, and it's just like pus in that respect. And then they just slide out. Because usually what happens, splinters are little pieces of wood, and they've got little barbs and little things. And what happens is they get lodged in there somehow. And you know, usually if it's just a surface splinter in between, say, the dermis and the epidermis, they'll just pop out. And you know, if you tear a little of the epidermis, I mean, it's dead skin anyway, so who cares, right? But it's when it goes deeper. One time years ago, I was working in a garden and I pulled up a weed, and a splinter got driven into my thumb. I mean, really, it turned out to be about that long. Got driven, and it would not come out. I could not get that thing to come out. I'd pull on it, and it was at the point where I was really afraid I'd damage it. So I just let it go for a few days. And then one day I noticed that at the entrance wound, it had a whitehead. And so I used a pin and opened it because there's no nerves there anymore. And then I squeezed my thumb, and this piece of wood popped out of my thumb. It was about that long. And it just came right out without any problem. Yeah, the body just rejects them too. Plus, if it's small enough, the body will just digest it.
That's what I'm saying.
Yeah.
Like what?
Yeah, that just tears it apart. The same way when a microorganism is attacked by our cellular defense mechanisms, macrophages and so forth, what they do is they secrete chemicals that just tear it apart, and they take it apart, and it's just gone. It's excreted. Anything that's not usable by the body is simply gotten rid of. And it's the same with wood. You know, the cellulose, we can't do anything with cellulose. So eventually the body will just rip it up. Cellulose itself is just an alternate sugar form.
Okay, so I was thinking about that because I know the splinter you said I was thinking about when you pinch yourself and
Yep.
that
Blood blister.
Obviously, that's fine. Ow.
Yeah.
So I was wondering what.
Well, the body, you know, the blood pool. Well, there, generally speaking, what you've got, because I had one of those right here. I pinched myself right there, and it was like a little blood blister, and it hurt for a day. And then a couple of days later, I just reached up and scratched, and it just popped right off because it was just under the skin. It had killed the skin. So it was basically a scab that had a little bit of skin over it. And that's what you'll have there. That'll just eventually just scratch off. Yeah. Well, if it's not bothering you, you probably shouldn't. Your body's taking care of it.
I see it though. Yeah, fingers talking.
Yeah.
I'm
Yeah.
Okay.
Okay. Let's take a break. Recording.
You don't require us to be live recording on the Zoom.
No, we actually are being encouraged to record all of our classes. And I generally do that so that 2 reasons. One is days like today, when we have students who aren't here, they still need the material. They don't get full attendance points on, but they do, they will get attendance as far as the school is concerned if they look at the videos. And I'll end this video today after we talk about dermatology. And pardon? Well, I give an assignment, something someone has to do to let me know. And of course, they find out at the end of the video what that assignment is. So they do that, and then I know they've watched it. So they get attendance as far as the school is concerned. But they don't get full points. So it's not a substitute for coming to class, but it also is useful, especially when I have this class that I teach, say like this one. I teach this class morning and evening. So I post the longer class as well for the evening students to look at if they want to and get more information. But that's that's what we do. But we are now being encouraged to record all our classes. I don't know where they're going to go, but who knows? Anyway, but I just convert them all to YouTube videos because everybody can look at YouTube. So let's go back to looking at skin diseases. The skin structure, as we know, we have the epidermis, the outer layer. We have the dermis, the inner layer of the skin. And in the dermis, we have things like hair follicles and sebaceous glands and sweat glands and other assorted materials, and obviously some blood as well. And then below the dermis, we have the subcutaneous tissue, also known as the hypodermis, below dermis. So the very top layer, the stratum corneum, is dead skin. I mean, it's dead skin cells, so they're constantly flaking off and being replaced. But the hair follicles come out. All of these different structures have disease or medical conditions associated with them. Hair follicles can get inflamed. The sweat glands and sebaceous glands can get inflamed. We can be damaged by cutting or injury, drying out. This Colorado, very dry climate. People often need to keep their skin at least a little bit moistened with oily substances like skin creams, or the skin will start to crack and you'll get fissures. Those fissures allow for infectious organisms to enter the body, etc. There are lots of infections. Got bacterial infections that can be on the surface or down in the follicles, or can result from damage. Cellulitis usually is something that happens after some sort of traumatic injury, and the body covers it over, but it doesn't really heal it, and it develops into an infection. You got fungal diseases. and parasitic diseases. The most common fungal disease being athlete's foot, but there are others. Toenail fungus we talked about that a little bit the other day. So we have that. Plus, then we have the parasitic diseases, pediculosis and scabies. Pediculosis is head lice. We have viral infections. We can also have other kinds of problems. Dermatitis and inflammation of the skin. There are a number of different causes of dermatitis. Sometimes it's due to irritants like poison ivy. Sometimes it's due to inherited conditions. So we have a lot of different kinds of, remember, itis merely means inflammation. So it's a descriptive term, but there are several different manifestations of that descriptive term. Hives are an allergic reaction. Eczema and psoriasis are both autoimmune diseases. Sebaceous cysts are something that result from this irritation, and you get a body that is just under the skin, a body of something, fluid or pussy material or even solid material, fatty material. We have little fatty lumps, lipomas, that are harmless. They don't look very nice, but they're relatively harmless. Frostbite is another one. Frostbite is when the skin actually freezes. And you can, if it's not severely damaged, you can simply gradually, gently rewarm frostbite and recover function. You'll slough off some skin or a lot of things, but as long as it's the skin and you don't actually freeze underlying tissue, you can generally recover from that fairly well. Other things are things like moles and skin cancers, sunburn. Sunburn is if it's a mild sunburn, basically just of the epidermis. We've all had that. You just get exposed. It's a little red. It's maybe a little tender for a few days and is okay. But if you have sunburn with blisters, you have your chances of getting skin cancer actually goes up by a factor of 4. Now, putting that into perspective, that's like saying it goes from 0.5% to 2%. I mean, we're not talking about a huge, all of a sudden you're going to get skin cancer. However, if you have continuous blistering burns, your chances start rising significantly. Okay. Striae are, every pregnant woman has seen them. It's the scarring that comes from sudden expansion of skin. So it's a separation of skin structures.
So it's striae. I just had stretch marks.
Yeah, stretch marks. That's what they are. Yeah. So, pregnant women often have them. People who gain a lot of weight suddenly will have them. Some of these things are extremely infectious, like impetigo. Impetigo is a bacterial infection of the skin. It's usually staph or strep. It is extremely infectious. Kids, when impetigo goes into a classroom at school, virtually every kid's going to get it because they are constantly touching each other and playing and that sort of thing. It's staph or strep. As a rule, both of these are treatable, but sometimes, and a lot of them can be treated just topically. We have lots of antibiotics we can use, but severe infections will often require oral antibiotics. Folliculitis is, remember the follicles, hair follicles are just barely the structure out of which a hair grows. They can become infected and inflamed, and it can be pretty unpleasant if it's extensive. All of us get a little bit of folliculitis now and again, you know.
So sometimes I feel like guys who shave,
Yeah.
that's how usually that happens, right?
Yeah, a lot of times guys who shave will have that irritation that will, because they'll slightly cut the skin. This, especially in the old days when razors were a lot cruder. I've got an old, I mean, we're not a straight razor, but one of the first handheld, you know, razor bladed razors, but it was very crude, and the blades, you can't get the blades for it anymore. But I somehow or another I acquired this thing, and yeah, you would actually scrape off some skin, and it would cause irritation and inflammation, and sometimes infection. Guys who have that should really consider using an electric razor, or they should consider growing a beard. And a lot of guys grow beards that when I was growing up, you know, beards weren't as common. I didn't actually grow a beard until I was actually working. But a lot of guys grew beards because they couldn't shave, because they would get so irritated. And it's more common in guys that that don't shave very often, that only shave, you know, once a week. You'll see this kind of reaction. So yeah, shaving will do that, and it's because shaving itself is an irritant. If you have relatively dull razor blades, instead of shaving the hair, it'll pull it, and that's really not very pleasant. But again, it can be superficial or deep. It usually is related to staph. Why? Because we have staph on us all the time. All of us have staphylococcus on our skin. So, and it can come from other things too. A lot of it has to do with, you know, basically just our lifestyle. So if you you know, if you get something like this, again, the real key is keeping the skin surface clean. But if you need it, well, there's topical antibiotics. Boils or furuncles are basically a deep folliculitis. It's when the follicular infection actually goes deeper into the lower layers, into the subcutaneous tissue. And again, this is a staphylococcus. Often they're very pussy. In simple cases, you can simply encourage killing off of the staph by using warm compresses, heating the skin. Remember, we talked about inflammation being a good way to fight infection. So you add a little extra heat to it. But if it's severe, you may actually have to have them cut out and be given antibiotics. Another one is if you don't deal with a furuncle, it can turn into a carbuncle, which is a much larger and deeper abscess. And they can actually lead to systemic infections. There, the treatment is almost always you need to have them drained, which means lancing them, and basically getting the infection out and then using antibiotics. Cellulitis, we talked about, it's an acute inflammation of the skin. It usually is a complication of some sort of traumatic injury. And staph and strep, again, are there. You have to watch out for it. It is there. You're going to see redness and swelling within a couple of days, and when it's not healing. Usually comes when you don't properly clean a minor damage. In my experience, the cellulitis comes from not properly taking care of minor damage. We talked a bit about acne. There are several different levels of acne. There's plain, they're just basically, again, the sebaceous glands, the oil glands get obstructed and can't clear oil, and they become, in that case, infected. Sometimes we need antibiotics. Usually the treatment is topical. We have all sorts of acne creams. It can get pretty bad. The really serious acne vulgaris, vulgar means ugly, just is an unpleasant disease. And it can lead to some really unpleasant side effects and long-term damage to the skin. So we want to deal with that. Treatments, we have our topical treatments that we use. We also have more advanced treatments, some of which have some very serious side effects. The drugs like for very severe acne, there's a drug called isotretinoin, which is a very dangerous drug. And in both males and females, it can lead to birth defects if the woman becomes pregnant or if the guy causes a pregnancy in a woman. So if you're taking that drug, you actually sign an agreement that you will either not engage in sexual activity or you will use at least 2 forms of birth control, both hormonal and a barrier method, because the rate of birth defect is extremely high in those. There are drugs that can trigger acne or make it worse. We move on to things like MRSA. MRSA, methicillin-resistant Staphylococcus aureus, is one of the superbugs, and it results. It's available, or it can be acquired either in hospitals and medical facilities like nursing homes, or it can be acquired through casual contact in gyms. We call that community acquired. It is being resistant to many drugs, and really the best way to deal with this is to be aware of its existence and be careful. Constantly wash hands. Don't share things like towels or razors or any of that. It really is, it's a really nasty infection. This last weekend I was at a function and one of the people there showed me a wound on his hand. Said he'd banged his hand and it had gotten infected. And I looked at it and my first thought was that, yeah, I said, you need to see a doctor. I did not name MRSA because I didn't want to alarm him, but I said, I don't like the look of that. And my first thought was MRSA when I looked at it. because it was not, it looked exactly like one of these pictures that's in the slideshow. Yeah.
Can you say that abbreviation?
Yeah, we call it MRSA, but it's methicillin-resistant Staphylococcus aureus.
Okay.
And it was discovered with the development of methicillin, which was one of the semi-synthetic penicillins, and it appeared first in Australia, or it was noticed first in Australia. About within a year of the development of methicillin, we started seeing this resistant organism appear, and it has become resistant to almost all of our drugs. So in reality, to call it methicillin resistant is just historical at this point. It's resistant to many, many antibiotics. The only one that seems to have much of an effect, vancomycin, is one nasty player. You don't want to take it if you don't have to. It has lots and lots of side effects on long-term use, and sometimes you have to take it for a while. So it's a nasty disease. We keep going. The fungal infections, Tinea pedis, athlete's foot, again, relatively mild. Basically, why do we get it? Well, where do we put our feet? Inside shoes. Nice, warm, moist environment, perfect for growing fungus. Athlete's foot, I don't think ever killed anybody, but it is certainly annoying. So we have various other things. Tinea cruris is known to many of us as jock itch, and it's basically something that happens on the inner thighs. Is again, it's an annoyance, and it's common, especially in obese patients, because they have their skin folded over and creating a nice, moist, warm place. Tinea versicolor is just a skin infection, a fungal infection that just patchy lesions and stuff. So we can treat that fairly easily topically. Tinea corporis is also known as ringworm, and ringworm is not a worm, and basically it comes from a focal point of starting, and it grows out from there, and the leading edge is usually brightly colored, and that's why we call it ringworm. Again, we have topical antifungals for that, and what we want to do is note that it is it's a disease that can be acquired by contact with a person carrying the fungus. Toenail funguses these are kind of some ugly pictures, but toenail funguses are common. Treatment is to use to use either topical early on to try and limit the function effect, or limit the spread. Or you may have to take drugs, oral drugs, and it can take up to a year. Pediculosis and scabies are parasitic diseases. They can be, we talked about nicks the other day, as opposed to using things like Quell. Scabies is actually a sexually transmitted disease, and it is a skin condition, and these guys get in there and they just really burrow into the skin, and it's really nasty feeling, I'm told. I don't have any experience with it. But not only should you wash your bedding and clothing in hot water, you should dry them at as high a heat in a dryer as they can tolerate, because you want to kill off these things. Viral infections of the skin, the most common is herpes simplex. Type 1 is like cold sores, and then type 2 is genital herpes, which is a sexually transmitted disease. It apparently, I've known some people who had, I've known a lot of people with cold sores. I've also known a few people who had genital herpes, and apparently it's extremely painful. But what you want to do is take analgesics, ibuprofen, Tylenol, whatever, and then for herpes type 1 or 2, acyclovir is still the primary treatment. It's a very effective suppressant. It doesn't kill the virus, it merely suppresses its development. Zoster, shingles, is related, herpes zoster is related to varicella zoster. It's the same virus, actually. Varicella zoster is chickenpox. And herpes zoster is a reflection, or is a manifestation of the fact that, again, with chickenpox, when I was a kid, we didn't have a vaccine, so we just got chickenpox. Somebody especially if it was during the summer, somebody on the street would develop chickenpox. Every parent on the street would send their kids to play with them because they wanted their kids to get chickenpox and get it over with. Chickenpox, usually after you've been exposed to it, you're immune, but shingles appears later in life. Most young people don't get shingles, although a few do. But mostly it's later in life. Shingles is one of those things that gets manifested by stress and other causes. It's a skin rash. These are pretty ugly pictures. These are pretty extreme cases. I'm told it's very painful. It arises because the drug, or the virus itself, goes and hides in an immune privileged spot between nerves, places where the immune system isn't going to seek it out, and remains sort of dormant, and then reemerges periodically. Although your book says it doesn't have, we don't know why it's reactivated, we do know that stress will cause that. So obviously stress results in the release of the steroid hormone cortisol, and that seems to be a part of that reactivation. Other things that can happen is that you can be immune suppressed for some reason, such as maybe a transplant, like a kidney transplant. We'll sometimes see an outbreak of shingles there, and some drugs will cause it. There's not a whole lot you can do about it right now. We don't have any treatments. So what we want to do is we use something like calamine lotion to dry out the skin and to try and limit the time. Verruca are warts. Warts can occur in many, many different parts of the body. They're all caused by one of the family of papillomaviruses. Remember, papillomavirus, a couple of the members of that family are the cause of cervical cancer, which is why we recommend a papillomavirus vaccine now for young women. You can have plantar warts, which are basically on the bottom of the feet, very painful, unpleasant. They mostly will simply spontaneously resolve, although you can use chemicals or what dermatologists use for treating warts is to freeze them. We call it freeze burn because they use liquid nitrogen, which is minus 80 degrees centigrade. And they spray that on, and it literally destroys the the cells that contain the virus. One of the reasons that we are concerned about many of these things is that they can turn into, they can lead to long-term inflammation and cancer. We have various forms of, I told you dermatitis is a sort of a generalized word meaning inflamed skin. There can be various forms of this. Atopic dermatitis is usually some sort of inheritable disorder, and it too can be aggravated by stress and other things. And then there's contact, which is basically we get contact with with some form of allergen, which can include soaps and cosmetics. I've known some women who couldn't use basically any cosmetics. Hives are an allergic reaction, basically antihistamines. Eczema is, although it doesn't really say in this thing, eczema is often considered to be an autoimmune disease. And psoriasis the same way. It's an inherited disorder, but it is an inherited disease or an autoimmune disease. Sometimes you'll see using coal tar. That is used, or we can treat it with UV light to destroy the cells that are causing disease, or disease-modifying anti-rheumatic agents, which are basically used for dealing with autoimmune diseases. Sebaceous cysts are usually fatty cysts that can appear on various places on the body. They're pretty benign. They can be removed. They're not necessary to remove unless you have a problem with your activities of daily living. If you look at some of the pictures here, those that appear on things like the eyelids usually become very difficult for people to deal with because it impedes their ability to see very well. They're not, they're not terribly, not very terribly common. People, when we look at moles and warts, what we want to do is look to see if something is a regular shape, and if the mole itself is fairly regular and consistent, then your dermatologist may or may not recommend doing anything cosmetically to it if it's in an area that would make it a cosmetic treatment, such as on the face, or if it were on a part of the body that was very uncomfortable, such as the buttocks, and make it uncomfortable sitting, you may want to consider having it removed. But what we also worry about is when it becomes irregular and different colored and flat, it can be a form of melanoma, or it can be a basal cell carcinoma, a skin lesion that's relatively easily treated. Basal cell and squamous cell carcinomas are almost always treatable and curable. Squamous cell carcinomas have essentially 100% cure rate by a surgical technique, and they're common. I've had one removed from my face, and it was not a big deal. So we talk about sunburn. We want to avoid sunburns that result in in blisters. The rest of it is the rest of this particular slideshow is a variety of skin diseases and some treatments that are recommended. I'm not going to go through all of those. I suggest you go ahead and take a look at it, simply because there's some very easily recognizable things that are associated with it. So, questions? We are now at 11:30. This is the time when we should, we'll take our last break. So I will put this, okay. So I'm going to just close this out with the assignment for Cheyenne and Glynis. You've had a chance to watch this video. So to let me know that you have, I want you to send me an email. And in the email, I just want you to send me a single word as the email. And the word will be Lugano, Lugano. So if you send me an email with that, you'll get some of your attendance points, and I'll call you as attending for the class. So that being the case, I'm going to stop this meeting and stop the video, and hope to see you all on